It's truly an honor for me to introduce both gentlemen here as Bob Hansen and Eric Wadsworth. For those of you who don't know, Bob received his PhD from UCLA. He's the Senior Associate Dean for the Tuck School of Business. He advises the Dean on strategy and implementation. He's the Faculty Director for the Center of Business and Society, co-faculty director of both the Tuck Business Bridge program and the MHCDS programs. His expertise lies somewhere at the intersection of economics and public policy. He's published in many journals. But did you know that his favorite movie is Fargo? And he's so excited that it's becoming a series. We just had a really interesting discussion about it yesterday. And he's been known to say, I do feel angry when government or companies announce important things on Fridays or major holidays. What's the honesty in that?
But as I said, I've been known to do that.
I have to thank you for helping me understand how supply and demand directly impact healthcare delivery. And as a physician, people come to you for your expertise. They expect you to really understand the Affordable Care Act. I really didn't have a clue. I said it's something about access, but thank you for very patiently educating me, because I was very popular at a lot of dinner parties, so thank you very much for that. So now another distinguished career, Eric, CFO of Dartmouth's Geisel School of Medicine through the 90s. He has a PhD in Organization and Management from Capella University. He explored the linkage between cost and quality in healthcare. His research and publications focus on cost measurement and cost management in healthcare. He's an assistant professor at TDI in the Geisel School of Medicine. He teaches on a variety of finance and healthcare topics. He is the faculty co-director of the MHCDS program. He's the associate of the TDI Office of Professional Education and Outreach. He's a National Forum presenter with the Institute of Healthcare Improvement, IHI. And Eric taught me about accounting. This was no small undertaking. I was the one who got the 0 on that online MBA program. So despite that, he actually very patiently explained to me that staffing costs can be both variable and fixed. It was very challenging for him. Thanks for helping me develop a basic understanding of financial accounting, analysis, and budgets. I now question how the service I offer as a physician, how does it add value to my patient's care? Eric and Bob, I owe you both a tremendous amount. Because of both of you and what you have each taught me, I am better positioned to make financial decisions at my healthcare institution. So thank you.
Thank you. So this is kind of our wrap-up. A couple questions that we'd like to explore. We've got the organizers from the class of 2013 up here, who were introduced last night, so I won't take time to run through those intros again. But two questions we want to start with. Those questions are, what are the themes that emerged through the discussions both yesterday and today for you? What are the important things that you heard that resonate with you and start you thinking about delivery of care in different ways? And then the second question is, what did you hear that you're going to take back with you and think about how you're practicing in your piece of the healthcare delivery system, perhaps in a different way? So those are the two questions we'll start with. The ground rules are a little bit different. We'll ask the four members of the organizing team to respond to those questions, but you're allowed to jump in at any point. In other words, if Yaz says something that ticks you off, don't wait until we call for questions. Jump right in and respond. So we'll just work through the group in order, starting with Kenny.
Oh, no. Start down there.
Yeah. Will's jumped in. Yeah. Will's always ready to fill the void. Thank you. And
gonna start with the low bar.
But feel free to have this as a discussion, and then when it's clear, certainly before 4 o'clock, that we've had that discussion. I'll wrap up with just a few thoughts. So,
Yeah.
Will.
I think one of the big themes for me for the last couple of days listening at the symposium is when we started the class, 2013, I think a lot of us came sort of expecting answers. We're in this fee-for-service model. You can't do both at once, the one foot in each canoe. But I was struck with the last couple of days listening to the talks, how many people talked about, we can start here. Here's where we can change the delivery system even while the payment reform is pending. Even to the point of, Robin Lunge I'm looking for Robin, all right, giving her talk today on Vermont, it was interesting to hear her talk about how much they've done around the healthcare delivery reform before the single payer goes in place. So even in a situation where we can actually control the reimbursement model, they really looked a lot at, what's the delivery mechanism, what's the system, and let's start to fix that now. And I think I heard that themes a lot, Jeff talking about Oklahoma. So that was, for me, really invigorating, really refreshing compared to a couple years ago. I think for those of us, before the program saying there's really nothing we could do, this is frustrating, we're in, competing delivery models. So that was, I think, probably the most important theme. A couple others, I think data analytics, hotspots is being sort of a trend that comes up, but I think a lot more people digging into how do we use data to start with a very large, complex problem and bite off a small piece that we can handle. And Jeff's example around the case management in Oklahoma, you talking about patients that are over 85, that you can really impact. So I think whether it's hotspotting or using data and analytics much more in healthcare, which a couple years ago was tough to get anything, even basic cost accounting. So I think that's an encouraging theme to hear about using data to drive the business instead of the other way around. And the last one, is really around relationships. We learned a lot in the program around change management, but I was interested in the CEO conversation where the relationship management came first in the sentence or in the story around how it affects change management, around informal decision-making, around the trust you have to build, versus I think people so quickly jump to, I have to change the culture, I have to work on this change management project, and not thinking, hey, the very first things is building those relationships. So I think those are the three themes that really jumped out at me the most the last couple of days.
Great, and I agree with all of those. But the one thing that was so palpable was the talent, the passion, and the energy of every session. And that started yesterday and it continued through today. The session one, the one thing that emerged over and over again is right-sizing the workforce. Be it Jeff with using care managers, with Pat and his team leveraging technology to right-size the care the patient's receiving. Why are patients coming from community hospitals to tertiary and critical access hospitals when the care can be delivered equally as well in the community, probably at less a cost? Ed Marin was able to talk about all his work and how he was able to disseminate that work throughout multiple healthcare systems, which was very impressive. Robin went on to speak so strongly about how important and how she discovered that it was the relationships that needed to be developed between hospitals and long-term care facilities and mental health facilities. And I spoke a little bit about that as well. Transitions of care in medicine are broken. And patients are vulnerable through that transition. So if we start collaborating, working together, we can perhaps change that. So Robin spoke very well to that, so thank you, Robin. Ziri Song, in his work, which I found was very interesting, because I really wanted to know what was going on in Massachusetts. I hadn't heard anything, and I knew they were doing it for a while. And one of the things that even at a loss, and it wasn't until year 4 that Blue Cross Blue Shield kind of broke even, yet they hung with it. And I thought that when the change came, it would be by no longer incentivizing or giving money for quality improvement initiatives, but really the return on the investment came from utilization. And that at the end of the day, I think that's what we're all about. Carrie Carolla spoke about, gave me a snapshot on ACOs. 55% of patients in the United States have access to ACOs, and half of the ACOs are physician-led. Physicians, one of the things, getting them motivated to lead and take charge has been a challenge, because I personally believe that we as physicians have abdicated the throne long ago. And now's the time. If we do not engage our physician staff to really lead this change, it's not going to go anywhere and it's not going to be disseminated. So I was reassured when I heard that they've been engaged in the formation of ACOs. Lastly, the last group was very inspiring. Tremendous leaders. They all spoke about change, disruptive change, pace of change. How do you engage the naysayers? You know, how do you move something forward? How fast should change move? For those of you in medicine, sepsis is a huge initiative. There's literature out there. There's a landmark study by Manny Rivers in the New England Journal. Everybody says that's a great study. It's double-blind, randomized. That was published in 2001. So that's 13 years ago. We believe it's good clinical care, and yet that hasn't disseminated. So I'm up against change that moves so slowly in terms of changing clinical care where it really matters. And how do you get that sense of urgency? And yet at the same time, there's so much change with technology and everything else that's coming so quickly. How do you manage change that's coming at you at two different paces? I struggle with that. And lastly, but most importantly to me, was when they were speaking about how leaders can get down into the weeds. I have been known by this group as Wolfgang. Well, some people call me Wolfie behind my back. And you know, it's been a struggle, but I was validated today that yes, you can get down in the weeds. As long as you get back up, I understand that, but okay, I'm working on it. So that's what I got out of today's session.
You're not bitter at all about
No,
Wolfgang.
not at all.
I'm glad you can read your notes because I took a peek and you definitely have doctor writing. So. All right, well, I'll start with this morning. One of the things that kind of amazed me as I've been sitting here for the last couple of days is the amount of innovation that's taking place at all of our organizations, kind of at the speed of light, I think. And I was really impressed by Brophy's description of what he was doing, especially leveraging Epic, which reminded me of that whole idea of the adjacent possible. For those of you who came to the learning excursion at UHC, and Steve Johnson presented there, and he's an author that talks about the adjacent possible. You don't have to build it all yourself, but if you can leverage something that you've invested $1 billion in to do something that it was never intended to do, right? That adjacency, that's where the innovation can really play out and really work to your benefit. And just kind of an amazing example of that. And then I thought, well, I have to go talk to Brophy, and I think I may actually have to go to Iowa. Never thought I would say those words, but I will. I will. I'm
Where you been?
I know. Well, you know, that's why I don't want to. So I really, I think that whole creation of a new performance engine is such an incredible conversation, because I think many of us are facing the challenges of creating a new performance engine with the challenge of the existing performance engine. And for those of us that are in the payer world, oh my God, can't even begin to tell you how much that is very much real in our organization and in our industry and marketplace right now. Yes, hey, that's exactly what Eric wanted.
So Sarah, who's here at Dartmouth, we actually have so many parallels going on. We actually met after the discussion today, and I think that's going to start to form hopefully a nidus where we can actually have both groups working together, because we're at similar stages with different things that are both equally important to our groups. So I literally just walked over here with her this afternoon, and I probably got about 15 ideas rolling around my head now, and I think it's just phenomenal. So just being here has allowed it, once again, to be an incubator.
And of course, I want to go and add to your ideas with hers. So,
yeah, absolutely.
You know, and participate.
And there's always
in
room in Iowa for one more. And Vermont.
Okay, I'm going to keep going. The other thing in the IT session, and I don't know how many of you attended that, because I missed Robin and others because I wasn't in that session, but the opportunities around data integration and the lack of interoperability that still exists in the system that creates incredible challenge for us every day. and it doesn't stop us from innovating, but I think we're still innovating in fragmented ways. And so as we move forward, we'll continue to fragment the system if we can't think about how we solve for data integration and that interoperability. I think it's an incredible opportunity for us to really solution that together. So that was something that I walked away from there. And then something from yesterday that I didn't want to miss the opportunity to talk about, since Ryan Armbruster's from my team, who was here for human-centered design. Amazing response from so many of you, and some of you who have projects that you're just kicking off or that you're in the middle of, where you believe that human-centered design could make an incredible difference to your thinking and how you might actually design, build, create, and launch something. And I think we're just at the tip of the iceberg of that. And I think it really speaks to the recognition that we want to have an emotional connection with the people that we work with, the people who work for us, the people that we serve collectively, and that it's really important for us to understand their perspective and point of view in everything that we build. And if we don't, we actually fail. It is a failure point for many of us in all of our billion-dollar projects when we don't actually take that into consideration. So I think more to come there, and I have a proposal that I've already been thinking about for Katie about how do we do more learning around that together, and really actually almost create a project that everybody can tap into in terms of the data. So I'm thinking Ryan doesn't know it's coming his way. And then I think in that C-suite one, just a couple, I think there was a lot of rich dialogue there, but what I would say is, transformation requires transparency. I think that is so true. If you're not a sincere individual when you actually have to face change in your organization, no one will follow you. And so it's really important to make sure that you got to tell the truth about why and the trajectory. And maybe some of those folks won't be working for you eventually, but you want to help them to be able to go somewhere else where they will really be able to benefit and continue to be really beneficial to the kind of organization that they can work for. And the other thing is avoid the Peter principle, because actually I think that's the principle that Sid was talking about, is we suffer. Austin talked about it, and he gave the example of trying to put salespeople in management, one of the worst ideas ever. And so that Peter principle is something you have to look out for. It's alive and well in at least corporate America, I can tell you. So
Madison, for sure.
Those were some of my observations. Okay.
Wow. So I actually think I'm more interested in what everybody here has to say than what I have to say. So I'm going to just be brief and say that I think the first session was amazing in terms of where we've come. Think about where we were 5-8 years ago in the healthcare system as the ACA was just being discussed and so on certainly before it passed, and where we are now. We've got all these things unfolding that are just exciting to watch, and this morning's session was one after the other. Back to last night, that's an example of the Governor Cornett speaking about something where you can really make if you have leadership on board. Wow, that just blew me away, how much change you can make in a community, going from being the fattest to the fittest. Pretty impressive. And if we could only do that same thing in healthcare, going from the fattest system to the fittest system in healthcare, that would be great. And I think we're well on the way. I was blown away by my colleagues and what they've done in the time since we've been here, and I humbled by it. So in our session with Ellen leading, I'd still like to know what's going on in Massachusetts, Barb, because I learned a little bit, but I think it's very confusing and it's very fragmented, and everywhere you turn, there's in the evolution of change, there is confusion, and I think maybe 10 years from now we'll all be in a much better place. But while we're in the phases of change, it's very challenging to look around. You put your head up in Periscope and you see so many different things going on, and it seems like they're all going in different directions. And I for one, struggle with, well, how do we pull it all together? How do we row the oars in the same direction? I don't know if you guys do that. So, and I think that, we have changing models of payment, people on the ground doing the actual work, not really on board and not really knowing what's happening. I still think we have a long way to go. So I don't mean to be negative. I mean to be optimistic that we are going in the right direction, and some of the case examples this morning really showed that, and what's going on in Vermont. You know, these things are all positive, but we still have so far to go, and we need to engage our colleagues. And, you know, I'm glad that I came up here for the past couple of days to sort of drink more Kool-Aid, because I need the recharging. And one of the things that the messages from the day was, when we go back to our places, we still have all these other people who are confused and frightened and threatened, and how do we get them all on board? So that to me was a message, is, you know, reaching out to everybody. The relationship piece is really critical. You know, the C-suite thing was, I think, really amazing to hear these people talk about the importance of transparency, like you said, the importance of relationships, the importance of getting people to work towards a common goal. And I think when you have a broken system like our healthcare system, it takes even more challenges. As Greg Meyer said, you know, we're sort of starting behind other businesses and you know, entities, if you will. And so it actually makes it even more challenging. Eliminating silos, a critical message, and just being willing to take on the challenge of leading change, even though it's a little bit scary. I think being willing to, you know, Spiegel's comment about, you know, speaking up and making your voice heard is a major message, and doing it in a way that's not threatening, that makes other people feel like you want to help them and bring them along too. So I think that's, you know, I want to make one other, separate for a second and make one comment about this conference, which is, you know, this is the first annual, and I'm thinking to myself, oh my gosh, look how successful this was, and fast forward 4 years, we're going to have 4 more years of MHCDS people who are all going to want to come back here, and they're all going to want to bring their colleagues, you know, 2 or 3 or 4 invites each, and we're going to have a conference of probably, you know, 1,000, 1,500 people that will be the force that leads change. So this conference in and of itself, I think, can help transform American medicine. So let's keep it going. But pass it off to you now.
Yeah.
Let me try something, say one thing that struck me, and end with a question for the panel. I'm probably suffering from the recency bias, but the C-suite panel was very striking to me. Mm-hmm. I'd hate to be in an interview with Eric Spiegel, for sure. But that's kind of the source of my idea here and my question. The idea of driving change and earning the right to do that. But the first kind of thing is there seemed to be a presumption lurking on that C-suite panel that change is good by and of itself. I mean, I don't think they ever said good change or successful change. It was just change. And I think there might be some truth to that, but that's the first element of the question, is just embracing change. Is that attitude really important? And then I guess the second part of the question is, how do you instill in the people who are working for you and the people you're working with this inherent desire to drive change? I mean, I struggle with that. We have a lot of forces of change in the education industry right now, and I've got people in charge of different parts of the school, and sometimes I wish that they would take a little bit more of the opportunity and run with it, and I don't know how to get them to do that. So is change by itself good, Will? And how do you get people to embrace it a little bit more?
Yeah.
I mean, all of you guys do, but
Yeah.
how do you get everybody else to?
I thought it was a really salient point. I think we think a lot about change management based on, one project or one opportunity or one business design. It was a really important point to say, how do you create an organization where they're change ready? And, I think that was Austin. I do think that that's incredibly important. I think, at the rate that healthcare GDP is growing, the cost, aging population, complex comorbidities, it's only going to get quicker, faster, harder. And the idea of thinking about, a culture of change ready, I think it was a really good paradigm to start thinking about, because it's, I've been down at Bay State for the last year, which is a 700-bed hospital, and talking to the physicians recently about, we have ICD-10, which got delayed, which I'm okay with. But we have,
Kevin.
yeah, we have, yeah.
Not so much, yeah.
But we have all these, big giant projects coming up, and, the 2 Midnight Rule, which they started and then delayed for a few months. But all these big projects, and, one of the physicians said, when are we, looking at the calendar, when do we have the pause? And I stopped and I said, I don't think there is a pause. And, unfortunately, I think it's just going to get faster. And I think to your second part of the question, which is, how do you create that culture? How do you prepare them? I think we have to do a lot more around articulating the vision of where this is going to bring us. And I think we get so busy with, regulatory requirements and CMS on us and JCO standards and getting all this stuff in place that, we had a class in strategic communication. I think we could have spent more time on it to start thinking about it. And I know our management team, for myself, has been every message that we send out, looking at the mix of that message to say how much of it is about the change and how much of it is why the change, why the vision. And I don't think we do enough of it. I was impressed with the C-suite talking about how much they think about, the vision and the message as much about the change. I would agree. Change ready is an important culture.
Barb, how do you get everybody motivated and embracing it?
It's a little easier for physicians because we're always taught to question the status quo. Whenever I take care of a patient, I know there's probably something I can do differently to improve that patient's care. And I approach everything from that viewpoint, whether it's the one patient lying in front of me at the ER or it's a bigger change. How do you engage people? How do you create the passion for change is a challenge. Change is disruptive. People like doing things the way they always do it. So here you are introducing this new way that's going to disrupt their life and perhaps add to their workflow. But for me, again, I've run a lot of performance improvement teams, and I always have a patient on the team. And I think that really inspires us to really think about why we're here, why we're in it, and why it needs to improve. I talked to you earlier about Ruth. If there's anyone in this room who doesn't realize that care has to change for Ruth, and Ruth is just one patient. I could take every patient who probably presents, whether to a doctor's office or an emergency room or an inpatient, and realize there's an opportunity to improve that experience for that patient. So that's how I approach it. And having a patient on the team is really motivating. And again, we think about change as these huge obstacles. Maybe I'm focusing it more on a micro level and then expanding it to a macro level. And I think I can inspire others to change. What I struggle with is disseminating that change. So I've done some work at LIJ, and it doesn't disseminate to another hospital in my healthcare system. Change that's cheap and has improved the care for the patient, has brought back, higher value care to our patients, yet it doesn't leave my building. And that's what I struggle with. How do I take a hospital that's in Staten Island and engage them and get them to believe in what we believe at Long Island Jewish Hospital? So I don't have the answer to that. You communicate up, down, left, and right, and yet somehow you still miss a big group of people.
Yes?
I think it's a natural human thing to not actually want to have a whole lot of change unless you have a certain kind of personality. And I once worked for a crazy marketing VP. I mean, he was crazy. So every week when you would come in, you didn't know if you were going to be sitting in the same desk because he would have moved you, or if you were going to be working on the same thing because he would say, you're not going to work on that anymore, you're going to work on this now. And that's how it went. So you were in this constant state of change. And so if you couldn't kind of go with the flow, you couldn't actually work there because it was going to do you in, right? And I somehow worked there for 12 years. For him, a good portion of that time. And then one day, as part of a leadership program, I was asked to do this River of Life that was all about my career, which of course I never felt like I provided any guidance to. It was like, it was like this all over the place. And he was a major influencer in the career moves that I made because he made me like, I was so used to change, it became part of my personality, which I didn't ever think I would have said. I would have embraced that. I would not suggest that this is the baptism by fire that most people should go through. Instead, I think, one of the things, especially in this past 3 years, for a company like ours, change is being imposed on us. So we've been really trying to communicate to all of our employees that the world has changed. Whether we agreed to it, signed up for it, like it, don't like, doesn't really matter, because it's going to continue. And we know what that looks like to some degree. So we all have to be part of that. And one of the things that we do, and I'm not saying that it's the wholesale kind of solution, but I think it's one of the things, is that our CEO every year issues a challenge to our 145,000 employees that is related to what he feels that we need to be solving for. What are the issues of the day that an organization like ours needs to take on responsibly? And we do this, we have a tool, we send this challenge out. You have to see the response from our employees and how they participate. And in order for their idea to move through, they have to create a team, and they do. And how that actually gets to, we have an innovation day that we've had for the last 4 years on May 22nd, where the 12 finalists get to present in front of all of the senior leadership, including Steve Hemsley, our CEO. And that is all about change, because that is all about changing. It isn't about a new silvery, shiny thing. It's about changing process. It's about their point of view of what they encounter every day that they potentially know they need to solve for differently, and they're imposing change on themselves through the ideas that they bring forth. So we encourage that all the time, and there are ways for those things to get funded and for them to actually be able to execute them, because we give them support for that. So they're not all out on their own, feeling like they're gonna have to do it on their own. And I think that actually does engender this culture of change within our organization when we make it real by having them actually own some of it and impose it on the rest of us. That's the other part of it.
Ken, I don't imagine that you change the positions of your team every
No, I learned that, people die on the vine when you do that to them. So you have to have extraordinary resilience to do that. But
And Ken, in your world, the change is good mantra there must be a lot of naysayers to that idea.
Yeah, absolutely. I think, first, I think I agree with a lot of the other comments. These are great comments, but I think it requires a burning platform. So many things. One thing, it helps to have a burning platform, and we certainly have that in healthcare. And it's kind of like what you said, change has to happen. The train has left the station. We are no longer sustainable. I mean, it's the same thing that was said to us when we walked into our first class of MHCDS, which is that look at these curves, it's unsustainable. So I think everybody knows that in healthcare. I also think that inherently, as you sort of alluded to, Yaz, everybody fundamentally is altruistic. I mean, whether they're in the payer world, the provider community, hospitals, basically people are good and they are altruistic. They want to make things better. I agree with that. But I think it's also, so why? There's a conflict there. Well, everybody's altruistic. Everybody wants to do the right thing, but people are resistant to change. Well, those two are kind of like, what's the disconnect? The disconnect, I think, is that is one thing that you said, Yaz, which is to involve, and was the theme throughout the day, which is involve the people that are whose lives it's going to affect, whether it's physician providers, nurses, nurse practitioners, people, healthcare workers, whatever. They have to have a voice in this. They have to believe in the change in order for it to be effective. And so I would say that the C-suite people need to think about the consequences of the edicts that they might come forth with, and maybe before actually coming forth with the edict, actually engage with the community who it will affect and get them on board. Because I think change is hard enough as it is. What makes it easy, we need to make it as easy as possible, given how difficult it is to start with. And that involves making people feel like they have ownership, like as was said. So I don't know, and that also includes, don't make it worse for them. Don't penalize. Make it engage them, make them. There's a lot of other things that motivate people than just finances, for example, and that's to make them feel like they're part of a team. They're trying to make something better, improve the world. You know, it sounds a little corny, but I think that there's a lot to it.
Question? Yes, sir.
I have a question because I think if I ask each one of you to ask what change is, you probably have a completely different picture of what needs to be changed. And sitting here thinking about change is not, it's a process, not a destination. And I really think, again, the question is what kind of a health system we want to get at the end so people rally around. So as a provider, as a patient, as a payer, I can sign on to it. And then the other question really is, so I'm going to my office on Monday, great meeting today. The question is, what do we actually need to change? Am I changing the way I practice, the way I change the way it's funded, the way I do my paperwork? And I really think that's not because nobody would argue with change except if it's a bad change, and usually that's too late because that's the result of it. So I think I'm wondering if each one of you can ask, what do you actually want to change and why? And it's at what level of change? And I think we talk about, I mean, analogy I think about sitting talking, it was like somebody throwing a rock in a pond. You got ripple effects. That change, but you have no control after it. And you assume that somehow it tripled the right direction. And I'm not sure it's a good assumption because it's, I mean, at the other picture, sitting here as a provider, we know what needs to be done. We know what we want to get out of it. I mean, there's almost universal agreement. But as a provider, I feel like I'm in a maze and I have to go through it and bump into it till I get the other side. And somebody wants to give me another maze, but it's still a maze. And it's really not, that's not the change. That's you call coping or adaptation. I happen to be a psychiatrist, so I'm sitting here worried when you guys talk about change, because I can tell you change is hard. And it's, so anyway, so thank you.
I think one of the biggest changes that we haven't, so I agree with you. Of course, the question was about change. So that's why we answered that way. But one of the things that we have not really gotten to and that we need, a place that we need to get to is coordinating care. I think that's a theme throughout the entire MHCDS experience in the past couple of days is we need to, the change that where we want to be is where patients have very coordinated care, where they, and there were some great examples of this. I mean, Bro, you had some great, my gosh, I mean, great coordination of care. The discussion you had, Barbara, about your patient, and if you could turn to your, to somebody, and I think Jeff, you mentioned, where's Jeff Alderman?
He left.
You turn to somebody and say, you know, can you take care of this problem? You're the expert in this. You can actually make it happen. If there were a way to sort of, there's so much of things that we as providers, I'm a provider, and I get calls from patients, and they have problems that I can't deal with. I'm not the best person to deal with them, and yet there's no real coordination amongst all the different services. There's still a lot of silos, and that's one thing I think we need to do much better.
My aha moment came, I spent my entire career in a hospital. And when I was in this program, I realized I missed the boat. Healthcare belongs in the community. Really, a hospital's the failure. And that's exactly picking up, you know, what Ken is referring to. Care, coordinated, appropriate care in the right setting belongs out there. And the transitions as a patient moves through is where we should be focusing on. So I think for me, that was a big change. And I'm actually transforming an inpatient hospital to an ambulatory center for that very reason, because we need to focus our efforts and energy at providing better care, bring care to the patient rather than the patient to the hospital.
I think those are all important points. And kind of to address your question, I think it depends on what level you look at these things. So on a national level, it's sustainability. Can we sustain healthcare and have a healthy or relatively healthy population moving ahead without sacrificing education, without sacrificing a lot of the other things that go by the wayside when your GDP keeps climbing from healthcare utilization? Are we doing it smart? Those are questions we can answer, or at least we can delve into. And so I think on a 30,000-foot view, you can look at it that. For each of us, though, there's each components within our own systems which actually allow us to focus on, does it need to be changed? Okay, can we tweak it a bit, make it a little bit better? Is it going well, right? How do we actually engage the stakeholders to make them buy into the system? If I give somebody a brand new EMR and I make their workflow a gazillion times harder, they're naturally going to say, you know what, I'm not going to do this. So how do we actually understand the end product? And part of the component of leadership, I think, is that's where you get in there and you demonstrate before you can delegate. So as you're part of that team, starting to operate within it, you go, I understand the problem. I understand what's happening. I can engage the people around me to get to that point. And then you can set forth with your team to say, this is a problem. So you've identified a problem. Okay? And then you can work with your team to try and coordinate the care. I think every single one of us this morning had a very similar thing. I think all the paddles are in the water. I think they're rowing the right way. We're just taking different routes to get to the same spot. So I think there is a question. Can we sustain it? Do you want your children looked after in the best possible way? Right? I think that's the key. Every time I go into clinic, I say, I want to treat this patient like I want my kids treated. And I think if you go there, then the silos start to fall away.
This is more of maybe an observation. And Ken, you said it right when you started. It seems like there's a lot of great ideas flying around this weekend. It's certainly not disorganized, but there's just a lot of great work happening. But I think we should really challenge ourselves to be precise in what those good ideas are. I'm certainly walking away from this weekend with the understanding that there's a lot of great things happening based on the conversation this morning, and then hearing the folks this afternoon talk about reimbursement models. But what is effective? Like, precisely what is effective, and then how do we replicate that elsewhere? I think it's incumbent upon us, upon the people in the room, to communicate that. And I guess that kind of ties back into what the C-suite folks said. We have to be crystal clear in what we're communicating, and it's very, very hard. But that's what I'm certainly walking away with, is that there's a lot of great ideas, but we have to be precise in what those ideas are and the impacts they're making. And I think there's room for us to improve on that.
Just kind of had a follow-up to that question. There is, in the last 2 days, I've heard the terms alignment and vision, collaboration, and sustainability used quite a bit. I think every session, everybody had some of that talk. How much time and effort and investment do you make in those things at a corporate level, or do you feel should be made at a corporate level? One of the things that we do in our firm, we work with a lot of different healthcare organizations across the continuum, and it's usually the thing they try and take off the proposal or try and discount from, because it seems kind of fuzzy. So we all talk about planning and alignment. Internally we call it business physics, understanding the concept of the organization and then bringing it down to the burning platform from there. But it's usually the thing that the executive team wants to not do, to speed things up or to lessen the cost of the project. One of the things I think about, if we ever looked at that, visioning for a project versus making sure that we're aligning it with the corporate vision or with the stakeholders in general. Because all of the things, especially Barbara, one of the things that stuck was you talked about your experience with Ruth and how do I find out all these community services. Those platforms and that technology exist in several places and several iterations, but the problem is there's so many of them, nobody's ever picked one. Nobody's ever collaborated or aligned with any of those organizations as a large group of healthcare systems to make them accessible or make them out there. So.
We'll go with one more.
I have one thing. The discussion about ACOs was particularly interesting to me, and maybe you have some additional insight. I'm from a state with 83 critical access hospitals. I think most in the country, Iowa's right behind us with 82. Maybe Texas has 81, right? So most of these hospitals are standalone community hospitals that were really built around the attitude that every little community deserves its own hospital. And west of Wichita, Kansas, every community except 2 has declined in population in the last 10 years. And so that is obviously not a sustainable structure. So as we discuss this concept of an ACO, right, I'm in a very different world, but I'm convinced that we can learn from our urban counterparts. And I just don't know, how do I take that back to a place that is digging their heels into the ground and saying, we're going to war, and we're not going to lose this, we're not going to change these things. Any examples of rural places in the U.S. that have, maybe Iowa's the one we ought to ask, but what,
is getting the data on the actual health needs of each specific community. And I agree with you. Should every little place have its own hospital? The answer is probably no, right? But the way that rural America's kind of declined, you're right, they dig their heels in. Of course we deserve this, right? So how can you help them with the slow self-transition and self-realization that maybe they don't need everything? So I think that's part of our strategy with e-health, with telehealth. Having that ability to remote in, having that ability to still have some of the answers, but deploying that in a proper fashion. So having a good idea of what services are needed in which particular community. And that's where we're at right now. We're actually digging through the Hospitals Association data with a really sort of deep investigation to the data points. And then we're going to deploy our stuff based on what we see.
That's a very emotional discussion in rural Kansas because the hospital's the largest employer.
Yeah.
I'd like to pick up on that because I am currently transforming a community hospital, exactly what you're describing, but it's not in rural America, it's in New York, Long Island. We did a needs assessment of the community, and of a community of 70,000, only 35,000 were using our hospital. And what were they using our hospital for? The ambulatory sites, the ED, oncology treatment, but they weren't using us for the inpatient beds. So again, we build pillar programs, and that's what we're building to meet the needs of the community. Where we fail to do is really be transparent with the community with this information, to be transparent with the physicians, and to communicate that. So when the community initially heard that we're transforming this hospital, the message on the street was that we're closing this hospital. And like every community you've described, they feel entitled to having their hospital. Although I could tell you my inpatient census today on my medicine tele and ICU is 30 patients. How do you sustain a hospital when both surgery and medicine volume is going down? And yet focus on what they really need it for. So again, it's a challenge. You're going to get a lot of community pressure. And I agree with Pat in terms of really doing that needs assessment and really providing the community with what they need. We don't have to have redundant services. Our mothership is 15 minutes away by ambulance, and they're a tertiary care facility and can provide all those services.
Ours is not 15 minutes away.
Right.
And the solution to this is yet to be. This is a really big problem, and in the cardiovascular arena, let me just give you a very small example. We do about 12,000 PCIs in the state of Massachusetts, and we have, I think it's 12 cardiac surgical programs. The state of California, they do about 55,000 PCIs, 4 times as much. They have 122, I think, or 126 cardiac surgical programs. Think about that. They have 10 times as many cardiac surgical programs, but they only do 4 times as many PCIs. They probably do more than they should, actually. So you have community hospitals doing 30 to 50 CABG procedures per year. What sense does that make? Right. How are you going to tell that community hospital, which is counting on that income and counting on the work, the work, counting on the work that the hospital provides and so on for their community? How are you going to tell them?
But then it becomes a patient safety issue. We've seen it with OB.
Of course.
How many hospitals stopped doing deliveries because it was just not safe?
And so that, there are other ways around that, but best if you provide alternatives for them in some other way, like you're doing.
Right.
Terrific discussion. Thank you. So in under 5 minutes, I'll close this up. We'll start with some thank yous and then just some of my takeaways for us as a program how we want to think about this, and we want you to think about what went on this weekend. The thank yous, first to, and I'll ask you to hold applause to the end because we got so many, but certainly to our 4 organizers, terrific job. Thank you guys for taking the reins and saying we need to do this and bringing this together and making it happen. The moderators and panelists for today, wow, incredible. I think we all, for the sessions we went to, said that really, really helped push our thinking forward. Our guests, I was blown away by the quality and number and range and geographic distribution of our guests. I'm so pleased that you came, that you were interested in asking these questions. I'm so proud of our students for reaching out and opening up the conversation in that way. Our graduates and our students, you light up, you just light up the Upper Valley when you show up. We just stand back and watch you come in, and the smiles and the hugs, and terrific. And then the MHCDS team, the curriculum specialists, the tech guys all running around. Beth, who as the new manager of student and alumni relations, this is her first big event. Good job, Beth.
Yeah.
And then Katie and Alice, without whom this would not have come off. So thank you all. Thank you, Katie and Alice. So what do we do with this? I mean, the thing that is evident when this group gets together, and now it's bigger, it's 2 classes that have graduated, plus a number of students, and even some new students getting together. The energy and passion, I mean, it was observed several times, is overflowing. I loved Beth's image where she said, you know, I was thinking of MHCDS here, this group in Hanover is kind of the mothership. But now I look around and realize, no, the offspring is bigger and more powerful than the mothership. Remember that diagram we showed you at the very beginning with the tuck business, the marriage of the business skills and the clinical skills, and that fusion slide in the middle was this army of change agents, and it's taking shape before our eyes. It was a small little SWAT team, and then special forces, and the Army is taking shape. And then catch Ken's vision of 4 or 5 or 6 years from now. Lord, what's it going to look like? But how do we capture that energy and keep it going? Because you're going to go back to your institutions, which will suck the life out of you if you let it. And I think a few things emerged. It sounds to me like revisiting HCDS virtual grand rounds once a month or every other month with issues that you surface, where the content expertise is out there, not necessarily resident with your faculty, whether it is on care coordination or whether it is on end of life, where the conversation yesterday afternoon, lit up the boards, or it is on how do you motivate changing behavior in non-employed physicians, or whatever it is. As you surface those ideas, and 1 or 2 of you want to do a virtual grand rounds, or one interview the other, or you bring in an expert and interview them, we'll facilitate that. If it is a listserv, we can facilitate that. We can make that happen. You got to help provide the impetus for using it and giving it life, but we can facilitate that. If it is a searchable library of what projects are going on and who's doing what and where is content expertise emerging in the issues that we're struggling with, we can help facilitate that. And then if it's a journal, an ACDS journal, then let's go there. Let's do this. There's another thing that just kept coming to my mind this weekend that I think was reinforced. Kenny's saying it's tough to get others to think this way. We drank the Kool-Aid, but how do we get the others to think? Sue Ellen says, How do we engage the rest of our organization in this? And then someone said, and the CEO group said this as well, upstream education. How do we leverage this and get our bosses motivated around this? So the takeaway thought, or one of the things I want you to leave here with is, you need to start thinking of yourselves as peer faculty with us. You need to be teaching this the same way we are. You need to be taking this out into your communities, back to your institutions, and become teachers in healthcare delivery science. You can do this with our materials or without our materials. You can do this with us or without us. There are all sorts of ways to give life to this, but you need to become part of getting this message out there and rethinking of your role as a student and coming back here. And you heard a number of ways. You heard a number of folks have asked Chris Trimble to come help bootstrap that conversation in their organizations. You heard Catherine talk about this question, and Rob Shumsky just happened to have real expertise on point. So there are all sorts of ways of reaching out and putting this together with the distance learning technology. It's not expensive to do it. It's not difficult to do it. So we need to be doing that. We heard Kenny complain.
I never complained.
Yes, sir.
We heard Kenny complain, often a prophet is not recognized in his own country, or my spin on your words. And so bring in the outsider to help stir things up, and then you can pick up the pieces with, okay, so here's some ways to think about that. My final message is this thing needs to grow geometrically. We are not going to change healthcare with 50 graduates a year. We're going to do this as this takes root and grows. Patrick bought somebody associated with the business school, a director of their executive MBA program out in Iowa. Perfect. These are the people we need to engage in this mission and get that out there. So stop thinking of yourselves as foot soldiers in this army. You are commissioned officers. Take the reins. Start to make change happen with what you've learned. And before I start preaching, I'll shut this down and wish you a safe trip traveling home.
Thank you. Yeah.